UNICEF Kenya office.
Good morning. My name is Abraham. I work with Save the Children as head specialist. Thank you.
Thank you, Abraham.
Morning, my name is Judith Raburu. I work for UNICEF Health Section.
Thank you, Judith.
Morning, my name is Judy Amina and I work for Center for the Study of Adolescents.
Thank you, Judy.
Morning, my name is Teresa Anwar. I work with UNICEF HIV.
Thank you, Teresa.
Good morning, my name is Collins Basoni. I work for DSW.
Thank you, Collins.
Morning, I am Jennifer Wagoi. I work for DSW Kenya.
Thank you, Jennifer.
Good morning, my name is Veronica Kirogo, Ministry of Health, Nutrition and Dietetics Division.
Thank you, Veronica.
Good morning. My name is Lisbeth Kageni from the University of Nairobi. I'm coordinating a program called RADA that is focusing on all those issues that are affecting students while in the universities, affecting their learning environment. Sexual and reproductive health is one of them.
Thank you, Lisbeth.
Good morning. My name is Beth Kangwana from Population Council.
Asante, Beth.
Good morning. My name is Dr. Chege, here representing Kenya Pediatric Association. I'm a pediatrician. I work in Kenyatta University. Thank you.
Thank you, Dr. Christine.
Good morning. My name is Wamboi Kungu from National Council for Population and Development.
Thank you, Wamboi.
Good morning, everyone. My name is Jaba Kuno. I work for Elizabeth Glazer Pediatric Foundation.
Thanks, Jab, for joining. Thank you. Yes, next.
Morning, everyone. My name is Caroline Kabiru. I work for the African Population and Health Research Center.
Thank you, Caroline.
Good morning. My name is Anastasia Olembo. I'm with the Plan International in Kenya as a gender and inclusivity advisor. Thank you.
Thank you, Anastasia.
Good morning. My name is Gladwell Gazesha from Ministry of Health, Department of Non-Communicable Diseases. Thank you.
Asante, Gladwell.
Good morning, everyone. I am Charles Nyukuri from Plan International Kenya. I am the Influencing and Advocacy Advisor.
Thank you, Charles. Hello, we still have some people who have not introduced themselves.
Good morning.
Morning.
Yeah, morning, Daktari and everyone. I'm Elsa Odira from the Division of Neonatal Child Health, representing Dr. Laura. Thank you.
Thank you, Elsa. I know there are still some people who have not introduced themselves. And
Good morning.
Morning.
Good morning, everyone. My name is Susan Ontario. I work with Japaigo implementing the USAID-funded Afya Halisi project as the Deputy Chief of Party.
Thank you, Susan.
Morning, this is
Morning,
Florence Halisi.
Sorry. Florence, come again.
Morning, Florence Akinyi Afya Halisi. I work as a program officer.
Thank you, Florence. Someone else was speaking also.
Good morning. My name is Solomon Herrera. I'm the team lead for Afya Halisi. Thank you. I work for Japaigo.
Thank you, Solomon.
Good morning. I'm Beatrice Ochieng from Division of Adolescents and School Health. Thank you.
Thank you, Beatrice.
Good evening, everyone. I'm Dr. Christine Wambugu from the Division of Adolescents and School Health.
Thank you, Christine. Okay. Thank you very much. I think if there's no one else, I will introduce, I think I'll be introducing the rest of the team as we move along. And as I started by saying that, I just want to thank all of us for joining. If you know someone who should be here and they are not yet here, kindly you can just text them and ask them to join us. We had sent out our invitation to nearly 75 people. So we expected to have a lot more people in joining us today. We'll go along. As I said, my name is Dr. Anne Mwangi. I am the head of the Division of Adolescent and School Health. And within the division, just as the name is, we have the Adolescent Health Program and the School Health Program, which are closely interlinked. So the program has, the Adolescent Health Program has for a long time wanted to have an adolescent health strategy, considering that our division is the umbrella division for the Ministry of Health. We are the ones that lead and guide in terms of adolescent health programming. And so we needed a strategy that would help to guide the programming around adolescent health issues, considering that adolescents have multiple health needs, physical needs, they have economic needs, they have social needs, they have their needs are multifaceted, they are diverse in different ways. And so we needed a document that would support that. And for a long time, we decided to have that document, and definitely because of resource gap, we've not been able to develop an adolescent health strategy. Within the different programs in the ministry, like the mental health, HIV programs, sexually reproductive health programs, they touch on adolescent health in a way, but we felt we needed to provide a document that would support programming in a broader sense, so that whoever wants to implement an adolescent health program, whether it be a community level program, or it's a program at school level, or it's a program at the health facility, they would be guided by this document to support that kind of programming. And that is why we came together and decided to come up with this strategy. I want to start by saying thank you to Afya Halisi, a program at the JPIGO, funded by USAID, for coming in and supporting us in this initiative. We had decided to start this process last year, but as we all know, there were the issues of COVID and restrictions in terms of meeting, and so we were not able to do that. Again, Afya Halisi the project coming to an end at the end of this month. So again, we also had the issue of time constraints, and so we have had to work against very tight timelines. And even now we are still working with very tight timelines, because considering this month has 31 days and we are on the 3rd of March, we barely have about 28 days. And that is inclusive of weekends. So we really don't have much time. And that is why we are trying to rush against time to ensure that we have a final document by the end of the month. So we had a writing workshop last month from 8th to 12th of February that came up with the team that went for that workshop came up with a draft strategy. And because we could not bring all of us to the writing workshop, we felt it was important for other stakeholders, especially those who are not able to attend the workshop, would be able to look at the draft strategy, give us the feedback so that we can input into the document as we move along. And so that is why it was so important for us to invite you to this workshop platform. We scheduled to have it for 3 hours. It could take a shorter time than 3 hours. So please bear with us. We are not going to go beyond 12. We should be able to finish within the 3 hours. So this is an opportunity for those who have been able to look at the document to give us your feedback, your honest opinion, tell us what you feel maybe should be included in the different strategies, and let us just know what you feel about the document. We have been working with a team of 3 consultants, a very able team, who have been working with us and supporting us in this process. And I will be giving them an opportunity to introduce themselves. They will be taking your feedback, whether it's something you put on chat box or it's something that you voice verbally. They will be taking that feedback and it will be incorporated into the final document. So once again, just to reiterate that your feedback is very critical, and we are going to take it very seriously. And remember, as we are developing this strategy, it's for adolescents who we consider to be the ages between 10 to 19 years of age. So that is our age limit. And because we go as per the WHO definition of an adolescent. So with those few remarks, I want to invite Sami and his team to introduce themselves, the team of the consultants who have been working with us on this strategy. They introduce themselves and then they take us to the next steps. Sami, thank you.
For making time to be this very important meeting. I'll introduce my team. I think I'm familiar with some of you. Samuel Munyewin. I work with African Institute for Children's Studies, and I'm with my colleagues. I'm sitting here with Dr. Kiragu, Dr. Lucy, Dr. Nkatha. I'm not sure whether she's be able to join, but in terms of my background is public health, but I've also worked quite some years in matters of child development and child protection. And we do our work around research, policy advocacy work on children. We've supported a lot of legislation work. And so this is quite within what we do as an organization, which is also registered as a non-profit organization. Thank you so much. We look forward to listening to you because we've been part of the kitchen. It will be good to know what else we need to add to make this really the best tool that we can use to coordinate our work. Kiragu.
Good morning, everyone. As Samuel said, my name is Dr. Michael Kiragu. I'm an associate of Africa Institute of Children's Studies, a consultant from this work, bringing in the public health and policy perspective to this work. It's a pleasure to work with many of you. I know many of you, and I'm looking forward to receiving your feedback on this. I can see very many experts in this group. We look forward to some great discussions, some candid feedback, which will enrich this document. Thank you.
Thanks. I know we have a bit of time difference. Our colleague, Dr. Nkatha, is also a lecturer at the University of Pretoria, and she's in South Africa at the moment. I know we were scheduled to be able to connect. I don't know whether she's had any challenge, but her background is law, and this is also very critical because as you develop such a tool, appreciating that there are going to be roles around county, national, plus the fact that we are building this based on treaties that Kenya signed up to. So we thought it's very important to have someone with a legal mind who will help us look through this. And so that's why she's part of this process. I hope she'll be able to join at some point. Over to you, Dr. Anne. Thank you.
Thank you very much, Sami. I don't know how we move now because it was to be by Dr. Nkatha.
That's
we can't
okay.
hear you.
Okay, sorry. So I don't know how many of us have seen the program. Maybe at this point I could quickly share my screen on that. Just a moment. So like Dr. Anne has already mentioned, we can do also hours. So the first presentation should be on the principles that really is guiding this process. That is an overview of human rights-based approach. If Dr. Nkata is not able to join in right now, maybe she can come in later, but I could give a quick overview on that as I introduce also the strategic activities that emerged from the meeting we had, the writing workshop that we had in Naivasha. And after that, we will go into a question and answer briefly, but really we want you to give input into those strategic activities. So we'll have a group work. And this is where I was also requesting that besides your name in your, I don't know how to call it, in your name tag, so to say, you could add the organization. That will aid us to see how we can group us into the pillars, depending on the final numbers that we're going to be having. Then we will come back and discuss. There'll be presentations from each of the teams, and that will be basically to agree on what are the next steps. There are other consultations that will still be ongoing. Let me just mention. I'm not sure if you mentioned this, Dr. Ann, but I know there is consultation with the county. There's going to be consultation with the adolescents themselves later on this month. So we'll bring all this together and go back into another moment of writing together with a technical working group and be able to present a more final document. So briefly, this is what we have. I think at this stage, then I could proceed and share what has emerged in terms of the strategic activities, unless there is any other addition to how we can make this more efficient. Okay, so a moment as I share my screen. As I open my screen, I really want to appreciate those who worked with us in the about 5 days that we had together. I think that was very, very useful input. I will start off by presenting an overview of the principles that is guiding this process. We think that is important because you appreciate that many of you already do have strategies that you are employing in addressing various thematic issues. We did identify about 16 issues, so to say, that are affecting adolescents, right from mental health issues to, things that like teenage pregnancy. So all this, we looked at them from a pillars point, and because this strategy is more trying to link all the work that is being done by everyone and present a holistic approach to how we are going to then be able to address or improve the adolescent health and well-being in this country. So if I begin by just mentioning these principles that are guiding us in this. So number one, which like I mentioned, Dr. Nkata may come back and give more detail, is the human rights-based approach. In this, it's also in appreciating that in all work that we do, there are international guidelines that we have signed up to as a country and treaties that then inform what is it that we want to do. And also really that in a human-based approach, you're appreciating that there are rights which are inherent and that there is a rights holder and a duty bearer. So in such kind of an approach, we are looking at being able then to improve the capacity of both the rights holder and the duty bearer to be able to deliver on the rights that are expected of them. So as we look at this strategy, and as you look at the strategic directions and the activities that we have proposed, I'll be hoping that you can sort of point out, have we picked out all the capacity issues that are necessary for the various levels of duty bearers, knowing that this starts, when you map that, you have the first circle of intervention, many times the spaces where the adolescents are, and then moving on into the county and the national level. And we're not only looking just at direct service delivery, but also in terms of the ability to have the proper policy and legal framework to be able then to address this. So that will be our main focus of that principle. The second one is equity. Again, just appreciating that in any such environments or situations, what we are addressing now, that there will be populations that may have challenge in accessing a service or a right that they do have in healthcare. And it is then that the barriers that make it difficult for such populations to access the services are removed. And again, very much linked to a rights-based approach that you are not, you're looking at not necessarily talking about disability, for example. It's not a matter of service just where the person is, but how do you remove any barriers that make it difficult for them to have accessibility? If we have information that is being shared to improve or reduce the risk behaviors, is it provided in a manner that I can access it as a person with maybe hearing challenges or visual impairment? Framework that will unite all the various issues and enable us every to healthcare services. Basically emphasizing that it's not just the absence of disease, as WHO says, but it's also social constructs that come with it that should be able to make someone be able to be mentally, physically, and also socially in a good health status, so to say. So this requires also that then look at the factors that exposing, a population to the risk factors and or the determinants of health. So these are part of what we'll want to interrogate and look at is within the thematic area you're working or within, as a country, the way we're approaching things, have we been able to address a holistic approach to health rather than just a treatment point? So I know, for example, when we looked at communicable diseases, it can be very easy to quickly look at it from a treatment point, but then very important to look at, are there certain social constructs that then affect access to services or disease prevention? The other one is evidence-based. I think this has been quite a conversation in many of the thematic areas you're working in. And I know, for example, in HIV, we worked quite a while in doing EBIs, evidence-based interventions. And I think as a country, this will be a good point where we want to build on what works and also knowing what doesn't work. So being able to look at whether the strategies that we are proposing are enabling the various duty bearers, the partnerships that exist, will be able to inform and build on knowledge. Do we have mechanisms in which we share that knowledge, and make it more available to inform policy and programs? The other one is a participatory approach. And I think at the key of this is involving themselves in any decision-making, in any design work that is being done. And so that's what, of course, informs the plan that we have. We know that the time frame we've had for this process may not be fully, will not enable a complete, as detailed perhaps, participation and involvement. But this is a continuous process. But we also want to benefit from some of you who already have platforms where you have been engaging adolescents and be able to do it. But also make it a part thing that becomes institutionalized in all our work that we do on adolescent health, that will continuously provide platforms that do this. Maybe it is time to also begin leveraging on the existing platforms maybe the children's parliament that exists, and see, are we also bringing in the adolescent health issues clearly in some of the platforms that do exist? But I think the key message here, let's institutionalize this and make sure it's a continuous process. The other one is having country leadership, transparency, and accountability. I think this has been acknowledged a lot in many of the documents that have, WHO guidelines and all this, that we want to be able to provide clear guidance. And if you ask me, really, this, I think, is one of those critical pillars that we'll be trying to address in this strategy, that these efforts are not scattered, and that there are mechanisms for ensuring that there is adequate infrastructure, there is adequate workforce to be able to support this kind of work, that the monitoring and reporting is actually working well, that the tools are available. And also that in this, we make sure all the partners come in. I know the academia, for example, do a lot of work, the private sector. How do we ensure that all of these partners are brought in and are able to contribute towards the results that we do have as a country? And I know this is linked also to looking at M&E issues, but I think it's time also as a country we can be able to say, if we track this number of indicators, then we know that our adolescent will be in a good space if we progressively improve on them. So, the question of what are the minimum critical indicators that we need to track is something I really hope we can get guidance from you as stakeholders in this process. The second last, which is the guiding principle on multi-sectoral approach and meaningful partnership. I think the key word here is really having a meaningful partnership, appreciating that each person may be doing something a bit different, but we leverage on each other's strengths and build on that. So really enhancing coordination and allowing space for every partner to be able to contribute is critical. The existing opportunities, for example, the SDGs. The SDG has very clear indicators that we can build on and also emphasizes partnerships. So I think we can leverage on some of this. I know when we had the conference here, the UNFPA, so those kind of goals that had been set will be good ones to build on even as we go on. Lastly is the principle of adolescent safety and protection. Basically they do no harm, that in everything you do, you want to ensure that the best interest of the young people is what is being achieved. So this I think is critical, and we've got to be able to ensure that it contributes to survival and development of adolescents. I'm sure all of us gathered here very on that principle. And but working in child protection, for example, we really emphasize that every agency's work will have child safeguarding and guidelines. So I think we'll be able to see programs being done, are they being done in the best interest of the young people that we are trying to address their needs. So I just wanted to give that quick overview, and in the document that we have shared, to explain those in a bit more detail. The other very important framework that guides the overall framing of this strategy is the monitoring framework. That ultimately we want to see that the services, the health services are made. So this question of proximity, and accessibility, which is also includes the question of inclusion. Is it something, cultural issues that may come in and all that, gender issues that could prevent accessibility to services. Those are things that we want to think about. The cost issues, how do we, for example, leverage on NHIF to be able to improve access to adolescent, services. Then acceptability, the social context is very critical. And I think these are things, again, that may have to be looked at, even customized better within the context of counties, but not in any way negating some of the core principles that we've already mentioned earlier on. And then quality, that we need to move towards achieving the highest attainable standards of health for every adolescent as a matter of human rights. Ultimately, that human rights string should be what should run through the entire bit of service delivery or planning. At this point, I will go into mentioning some of the things that have emerged out of your contributions. So we picked on 7 pillars that are linked to some of those principles, but are also linked to international guidelines like the WHO guidelines. Number 1 here is one that looks at ensuring that there's an enabling environment for we think that the gap here is that, yes, we have as many policies and legislations that exist, but the question of enforcement, I think that came out in a lot of the conversations we had in Naivasha. We have policies, we have legislations, but they are not being implemented or enforced. So the question of accountability, or we do not have the resources for it. So some of the activities that have been proposed here, and you will notice that they will not speak, say, to mental health, to sexual reproductive health directly, but they are cross-cutting, is that through a stakeholder platform like this, and with the leadership of the Division of Adolescent and School Health, that we will have an advocacy for implementation of the existing policies and legislations. And this is looking at the various platforms, again, where the children are, and building on existing policies, the ICT policy, the school health, and others. So maybe when we now come to work, we'll need to be able to have gaps. So I guess some of this will require a gap analysis if there is any, but also then to just see how do we invest more in implementation. Then the health financing mechanism, looking at the universal health care and providing access to all adolescents. And I think one of the conversations that came out in Naivasha was adolescents sometimes are in this space where they need to remain a bit, let's say, discreet or independent. You know, you don't want to work with your parent into a health facility. And some of those will require then that how do we provide access to them, even including matters of financing that still allows that space for privacy, but still the role of communities and parents. Advocate for investment in specific strategies, such as school enrollment and retainment. So the stakeholders in this meeting, in the writing workshop, we did acknowledge that there are things that are not necessarily health, classical health, but they do directly impact on that. And so how can this team of stakeholders who have interest around adolescents also put their voices around structural issues such as school enrollment that will affect this? Then there is the question of healthy foods and healthy food. It came out that there is a strong campaign, marketing strategies that are being done. You know, some of them very strategic, long-term. You know, someone will be trying to put a particular brand of a product and make it appear like if you're eating this food, then you are in a certain class. And you know how those things appeal to adolescents. So how do we address these kind of things to ensure that the kind of marketing of products that are being done are not contradicting the policy directions that we want to take to ensure that our adolescents are healthy? Some bullets there are more specific. Maybe some of those could move later on into either thematic area issue or the specific activities that we want to achieve. The other one under leadership and governance is advocate for social protection of adolescents. And I think this is really important, knowing that there are quite a number of maybe adolescents who may be in a bracket where the economic issues and challenges around being able to access. How do we link what we are doing here to, say, cash transfer programs that are happening for certain households, so that then those same households are able to, when you're talking about conditional cash transfer, we also look at tracking the adolescent health benefits that come with such. And then lastly here is to develop policies and guidelines on intentional parenting. I'll come back again, but I think parenting was really, came out many times. It's one of those that was mentioned a number of times. We also appreciated in that meeting that there are already efforts to develop training curriculum for such, and maybe all we need is to make them more available and accessible to many more. The other one is strategic 2, which is empowerment of the adolescent as critical partners. So here we were looking at adolescents who have information that is correct, that then they are able to make better decisions. Yes, we are aware that decision-making, and maturity issues is something that is not, you don't expect the same thing for a 13-year-old as would be, say, a 19-year-old. But then I think when people have information, they're better off in making decisions and reduces the risk that they will do that. Some of the activities that are being proposed here is leveraging on existing tools such as social media, having very clear peer education program for adolescents, and a peer support system that maybe will be addressing specific issues. I think, there is such a rising suicide rates, non-communicable diseases, and how can a peer-to-peer approach be leveraged on, which some of you I'm sure have done some good job on that. So we could look at developing content and guidelines on how to do this that can be used as a tool across various thematic issues that affect adolescents. There was the point also of collaboration with counties, having minimum standards for how do you involve adolescents that counties can adopt and use them. So as you even do budgeting, annual budgets, how can we ensure that we have platforms that adolescents who are informed can engage in and be able to influence the kind of policies or budgets that are being allocated. There are certain toll-free communication lines that exist that could build on. I see we miswriting there 116, for example. But there are also those that are very specific to helplines. So we could build on this and be able to share resources to provide the information to the adolescents. Identify social media influencers. I think, at this age, that is very key. The role models, who is it that they listen to also help us pass this information. And that could be shared then instead of each person working with a few people. Collaborate with the Ministry of Education. And I must say, like one of the issues that was raised is child labor. We've seen progressively from evaluations, and when you read reports that we came across, that information that has been integrated in the school curriculum has been one of the most effective ways of doing this. So we think that it's a good thing to build on, and we should be able to continue that and see how do we include it in the CBC curriculum, for example. What are the health information that are being packaged there? We may need to have some reviews periodically and see how we improve on what exists. Let me just mention that we also did notice that there have been sometimes some contradiction on how one sector approaches things. For example, we have a policy on school health. And there's also a debate on whether we need a standalone training curriculums for that students are taken through, or should we only integrate it? So I think these are some good feedback if you have certain data that we can inform what we do. Lastly is appreciating that there will be certain group of adolescents who may have a challenge. And so socioeconomic challenge, empowering them and linking what is happening in terms of youth and economic empowerment issues to this work is very, very important. Delaying marriage, which I think is really important also, even on gender issues and what affects especially adolescent girls. I think these are some of the critical issues that were proposed. I don't know whether we are following. Do I finish the 7? Okay, I guess that would be the best approach. So number 3 is to strengthen the capacity of parents, teachers. During the workshop, we did map out spaces where adolescents mostly spend their time. So there was home, school, and other community spaces. And so we thought that it's important then that the people who are in these spaces are empowered to be able to respond to the needs of adolescents, because many times they're the first responders. And some of the activities that were proposed in this is strengthen parenting and community support, sort of a framework in which they can be able to, share information, respond appropriately to some of the needs. So that may go along with, informing parents and teachers. So specific training areas that will help them to be able to respond better. I talked about intentional parenting, again, building on the curriculums that exist, maybe review them, see, are there certain health issues that have been left out that we could bring in? And, things like self-esteem building that ultimately affect risk-taking among adolescents and how they respond to peer pressure. So these were flagged out as critical during our writing workshop. We need very targeted and maybe, sustained awareness campaigns with teachers and the communities, the parents, on things such as negative use of internet. So these are the critical areas that were brought out. Also recognition that there are already agencies that have mandate to drive some of these things. How do we bring them on board from a health perspective, like the Department for Children's Services? And building capacity of other stakeholders like the police, the healthcare workers, the volunteers, the community level. How do we build the capacity, giving them evidence on why you're doing certain things in a certain way, and also on how to manage even things like evidence, because I know especially on SGBV that has been a major concern. There are people who've made quite some investment in this, but I think there's much more and maybe requires periodic investment in some of these things in terms of training. Then mental health challenges was flagged out as really a key one, and I think COVID made this even more loud, that we need to really have capacity to be able to do assessments, to do community-based interventions and not institutionalized care only. I think as a country, we've done much more in institutional care, yet community-based approaches are much more within the International Convention on Rights of Persons with Disability compared to the other one is strategy number 4, which is looking at ensuring access to equity and quality services that are responsive to the needs of adolescents. Some of the activities that have been proposed here is advocate for adolescent focused protocols and training package for health care providers, that they need to have an extra lens whenever you're dealing with adolescents, that there are certain things which you need to do. More the same way we've done so much, say, in youth-friendly facilities for HIV. Also looking at other issues such as FGM, substance use. So I think the whole point here is to look at, do we have the right protocols and training on how to support adolescents whenever they come to various people providing services. The other one is the institutional mechanism for adolescent participation. like I said earlier on, we could build on and leverage on existing platforms, or look at what those that are working pretty well and build on them. Establish models for comprehensive and integrated adolescent-friendly clinics. Maybe some centers of excellence were proposed that then can allow an adolescent to access services. So I know here there's usually the balance between when you have a one-stop space, it's good that it brings everyone, but at the same time, I don't want to walk there and be seen being labeled that is, So what really is an adolescent-friendly clinic? I think is a good question that all of us could help answer. Then the cost of making this, because costing was again brought out as a key challenge, that sometimes when we are not very clear on what is the cost, what are the cost benefit, how does that fit into the budgeting process, the annual budget process that goes to Treasury. So having unit costs, being very clear on how they contribute to the benefit of the entire country were some of those things that were being identified, but also having investment cases for adolescent-friendly centers. Why must we do this? I think the more we go into a public financed health system, which is part of our human rights-based approach to this, the more important it is that we have clear investment cases for everything that we are doing to improve the well-being of adolescents. Develop and implement SOPs for health facilities that are meeting the needs of adolescents, and then have a national task shifting strategy where health facilities build capacity of adolescents in various aspects, certain aspects. And then lastly, they establish and strengthen infrastructure and commodities at adolescent health facilities. Number 5 is to sustain the community advocacy and engagement. I think this is very critical, knowing that some of the things you're going to address, such as FGM, substance use, are really also linked very strongly with cultural issues. So having communities, sort of brought on the side of where we want to go in terms of the policy direction is very critical. Engaging the right leadership who can influence that is very, very critical. So some of the activities that have been proposed here is to strengthen grassroots community engagement with targeted messaging on negative sociocultural practices, such as child marriage and FGM. Identify and empower community champions who can then be, the spokespersons of this. Advocate for accountability among duty bearers. So building capacity of civil society organizations, community-based organizations and communities is critical then in also, supporting the communities to engage better. Promoting safety and security for adolescents. Working with security agencies. We thought that is very critical because, again, how you supporting an adolescent who say is having a challenge around substance use, it really depends on how the security agencies are responding to that. So that we thought was very critical. Sensitization on the UHC at community level and among the adolescents to promote enrollment and utilization of these services. Then collaborating with the media practitioners, such as existing networks that are specific to media, rather to health. We thought this was some of the proposed. And lastly, is to identify and promote champions for adolescents and youth. The second last area is strategic direction number 6, which is looking at data, monitoring, research, and surveys. So, so 2 things here is, one, to appreciate that we've not had this one point that you can go and access information on adolescents in our country. And that will help us track progress, also be able to report to international treaty obligations. On a click of a mouse, you should be able to bring down or download certain indicators and monitor these periodically. So again, this will help us to base our policy making and program designs on the evidence that is coming from the data. I think Dr. Christine will tell you there's been a team that has worked in using, trying to use data, partly modeling and all that to be able to present the situation for Kenya. But some of these data actually exist out there. Maybe we just do not have a centralized way in which we collect and then collect that data. So some of the activities that have been proposed is to create a national dashboard, more the way you have a situation room, say, for example, for HIV. But we can have a situation room, a dashboard that tells us where are we on key adolescent health indicators for Kenya. And this, of course, will cut across the thematic areas. Define and disseminate national reporting indicators. So give tools out there, that can be used. Having national research agenda. As universities continuing doing their work, we should point them to where the gap in knowledge is. Things that we've been doing and we're not sure whether they're working. I know, for example, within the Ministry of Education, there's been a very clear request. What can we do around addressing teenage pregnancy? And those who've been implementing, is there a demonstration whether it works or it doesn't work? So I think such gaps need to be pointed out, and maybe have a mechanism in which we present this in a peer-reviewed journal kind of material, which our academic institutions can build on. Review and harmonize data collection tools, disaggregate data by age specific to this adolescent to inform decision making, and have regular biennial national adolescent health surveys, which then can provide us data. Lastly, pillar number 7. Sorry, what's that one? Yeah, is to strengthen partnership and coordination of adolescent health. I think, again, this could be really the elephant in the room here, that we need a system in which we have one point to call on matters on adolescent. And of course, the division for adolescent and school health is sure a very natural point to come here, and thank you for coordinating this. So some of the things that have been proposed to strengthen that is that we have a technical working group at national level that provides leadership. I know there's already been a TWG that actually led to this process. So we just need to look at how do we strengthen that, how do we ensure there are more voices and information from various partners that are included in that TWG. We'll need to cascade that to the county level, so also have a TWG at the county level, and have at the community level, work on the existing community health committees, but also bring in a lens on adolescents and what data they capture. So I think, it goes back into the tools that exist even at that community level teams, committees, to be able to improve coordination. Optimize public-private coordination and collaboration, and that also will include academia also, and then collaborate with the Ministry of ICT to use technology-based platforms for empowerment. So overall, these are the 7 areas. I can put this on the chat box maybe, so that for a quick reference, and as we go into the group work, you can be able to look at them. At this stage, I think if we could have some questions.
Thank you very much, Sami, for the presentation. And I believe all of us were very attentive to that really elaborate presentation. So we will allow you to ask questions. You can raise your hand against your name so that we can see who has a question. It could be a question, a comment, or just anything that you'd like to say in regard to that presentation. Feel free to do that.
Good morning.
Morning.
Yeah, this is Charles Samuel. How are you? Good friend of mine.
Nice to meet you, Charles. Hi.
Yeah, thank you. I am coming late into the party, so definitely I've not been part of the whole process, thinking through the whole development of the 7 strategic areas. So this is my first interaction with this, so my apologies if I may sound repetitive, but my first reaction is on the principles. I think I find them quite a lot. I will reduce the principles into 3 because there are some areas that are quite repetitive. So for example, from my level of thought, a human rights-based approach comes with 5 key elements, which is participation, accountability, non-discrimination, empowerment, and partnerships. That will automatically collapse a lot of the things that we presented. So I will remain with human rights-based approach, do no harm, and the evidence-based approach. These other areas, I will feed them into the human rights-based approach, but definitely this will be backed up by some text explaining. So I'm not saying you delete these items, but just feed them into the human rights based approach and give an explanation around it. Secondly, I think when you look at the activities, I think it was in SD, that's strategic direction 1. I think in bullet number, I think it's the second bullet, I think I would maybe start appreciating if we can have community members participating and even young people in the budget making processes. Because I think when we have to get into the nitty-gritties of what financing really means. And it's for them to appreciate that we have a budget cycle to ensure their voices are amplified to a level where they can come and dictate the budget making processes. So I will expect an activity around that. Thirdly, there's something on SD3, strategic direction 3. I liked the activity on internet, because I think somehow we always do not leverage on technology. Yeah, now I can see SD3. Yeah, great. So Google has developed something with the Communication Authority and other stakeholders on safe parenting. So I'm looking at ourselves, how do we build on to what Google has already developed so that we do not duplicate efforts, so that we are basically just complementing that. And finally, Sam and team, SD7 on public-private partnerships. I think this is one of those areas that's highly neglected. I think we may want to unpack what this really means, because in that previous engagement that I've just shared with you with Google and Communication Authority, we already have the 4 mobile operators in that conversation, the Safaricoms and the Airtels and the rest of the teams. So how can we leverage and take advantage of that space that is already existing to build on this? And finally, just the second bullet, the last bullet point, still in this same slide, the Ministry of ICT, they've done quite a lot in terms of having these technological platforms that have these conversations on such issues. So how can we build on the same? Over to you, Sam, and thank you for the opportunity.
Thank you very much for your comments. Sam, do you want to respond, or we take?
No, I was actually thinking, thanks, Charles, very good input, some of which maybe we could also harness during the breakout rooms, so that then we give as many people opportunity. Maybe at this point, we could have broad level responses, and then I like the feedback on the principles. That would be very important if there's any. then perhaps we could go into the breakout rooms and we could now go into the detail of the pillars. And during the plenary, if you realize maybe you
Oh, Samia, your voice has disappeared. I don't know if it's me alone. I can't hear you, Samia.
Yeah.
Yeah, we can't hear Sammy. So, Kirago, can you hear? Okay, as we wait for them to get back, maybe it's an issue of internet connection. I could allow Teresa, Dr. Teresa, your question, your hand is up. Then after that will be Veronica, then Caroline.
Okay.
Teresa.
Thank you, Dr. Anne, and really thank you to the team who sat down and pulled this together. Mine, I think as Sami was suggesting, maybe we can just give overall comments and then detailed comments can go into the breakout rooms. So for me, I'm really appreciative of what the team has done. And I do agree with the previous speaker in terms of trying to narrow down the strategic directions without losing the intended principles that we want to bring out. In one of the principles, I think it's strategic direction 2, whether we'll collapse it or not, I think we should go beyond empowering and also include engaging. So really looking at how we bring in, and somebody has just, and I think the previous speaker also just spoke about it, how do we bring in the young people themselves early in whatever interventions we want to talk about. So I would add the word engage, or see how best we can fit it into the principle. Because we're not only talking about a rights-based, but we're also talking about a human-centered approach. And those are, some language that we can play around with, refine as we go along. In terms of engaging community health volunteers, I think it's an idea, but we also have younger people, less than 18 years, who get involved with a lot of championing and advocacy. So rather than, I think this was in strategic area 2, rather than just limiting to community health workers, was it bullet, the third one from the bottom, probably add in issues around youth advocacy and how young people themselves, how do we engage prefects, for example, as youth advocates? How do we engage the Children's Parliament, as had been mentioned, as advocates for health? So probably not limiting ourselves too much, but broadening the scope of how youth can participate and adolescents themselves can participate in community level work. For SD3, I think I'll just suggest that we unpack what we mean by duty bearers. It tends to be quite gray. Are these social workers? Who are they? As other responders to adolescent health. For SD4 on equity, I think I'll just say for bullet 2, the issue of adolescent participation, I would actually move it to the empowerment SD, where we're actually engaging if we choose to go that direction. Then also on SD4, I think we tend to be a lot, still on SD4 bullet 4, we tend to be a lot fixed on adolescent-friendly centers. And there's evidence to show that it's not really the center, it's more the service that you provide. So you can have the pool tables, you can have the, the computers and darts and all those games, but does it really change health outcomes? And that's what we really need to think about. So For a strategic direction, I would consider investment cases for friendlier services, and then centers can be at activity level. If a county wants to put up a specific center, it should meet a certain level of services that will be provided in terms of youth friendliness. I would also suggest SD5 just to refrain from naming specific practitioners, because it's a strategic document. It has a longer life. If there are others who are coming in, then they won't be locked out. So that's for SD5, where we've specifically mentioned the KEMEP. And then in 7, I think the question I had was, how does the coordination between the National Technical Working Group at the national level and the county level, how do they talk to each other? So I was wondering if at national level, it's more of a task force where it's more multi-sectoral, and then you have subcommittees that can support TWGs. I don't know. I think the question is, we normally have, and in many sectors, we have national and county level, but sometimes how they speak to each other, how they interact, how they engage is what's missing. And for me, the game changer would be, that feedback loop from county to national and national to county is something I would consider. Then my last point is just maybe consideration of language rather than strategic activities. I would consider strategic interventions, so that if we have an intervention for capacity building, it doesn't, County X might do the capacity building as a didactic classroom the capacity building, or an online model, or a hybrid model. So I'll just suggest that we change in our strategic document, we change from activities to interventions. Over. And thanks for the opportunity.
Thank you very much, Dr. Teresa, for the feedback. It's well noted. We go to Veronica Kirogo.
Okay, thank you, Dr. Ann. Mine, I think, is a good document, being an initial draft, and captured quite a number of issues. I had a few additions when I was looking at the issue of empowering the adolescents as critical partner in their own health. I want to put a disclaimer. I may not have read the full document, but I'm looking at the adolescents in difficult circumstances, like the ones including the street adolescents, including the orphans and vulnerable adolescents. We need really also to see how that we are not leaving them in this strategic document. And a good point I noted in, I think that was SB3, that is strengthening the capacity of parents and teachers. And maybe just sharing experience, one thing we have from nutrition, we have found when we are sort of using the school approach, is that in putting or integrating your messaging in the curriculum is one thing, but then empowering the teachers with what is it that we want the teachers to say around the issues we have put on adolescents' health in the curriculum, translate to standardized way of messaging, so that we don't leave teachers interpreting. And I have in mind, then we may need maybe a teacher reference manual in terms of adolescents' health aspects that are in the curriculum. I've looked at the
Veronica, your voice is breaking.
I've picked it because I see her
Sorry,
during the COVID.
Veronica,
Can you hear?
Veronica, we lost.
Can you hear me now?
We lost your voice. Yeah, your voice started breaking immediately. You talked about the teacher's reference manual. So the next point we didn't quite get you. So we kindly repeat.
Okay, thank you, Anne,
After the
for
teacher reference
that.
manual.
Yes, in terms of put in the school curriculum on issues that the children or the adolescents be taught in terms of health, we may need to expound it in a form of a teacher reference manual, so that we don't have teachers trying to interpret and at times they get it wrong. The other one is on the adolescents who have been sexually abused. I don't know whether we have taken care in terms of how we target them or assist them in from that trauma. Then finally, I'm also looking at the issue of coordination. Yes, we have the Adolescent Health TWG. It will be important also to see then because like nutrition, we also have an adolescent nutrition working group, which of course we should feed into now the umbrella one. So it will be good also to see now in the different departments in the health, if there are other specific ones dealing with adolescents issues, so that we are all converging into the umbrella of the Adolescent Health TWG. That's something that I would propose we need to explore. I think so. Okay, yeah. In terms of linkages, I don't know whether the document has is talking to the linkage with the social protection, because they also are targeting some adolescents. We see how do we also take leverage on their systems. I think for now that is what I have. Over to you, Anne.
Thank you very much, Veronica, for those comments. We have noted them down. We go to Caroline Kabiru with the HRC.
Thank you very much, and I hope you can hear me. And
Yes,
I do. Thanks. I think this is a very good document and will be useful as we move along. I have specific comments on some of the strategic activities that I can share via email, but some of the things I wanted to point out as a general comment is, one is, I think there are certain things that are appearing in sort of the strategies, but you don't quite catch them in the introduction. So for example, I think there are several references to female genital mutilation, but when you read the background, there's nothing that has been provided around how the extent of the problem. And I think it would be useful to include that in the introduction so that the background is really a good basis of where the country is at in terms of adolescent health. I also feel like it would be useful to include a section that's specific to, rather to strengthen the current section on the mapping of policies, because I just glanced at it and I noted that quite a number of statutory, sort of laws as well as policies are missing. If I could cite one, that would be like the prohibition of FGM. Other policies like the school health policy, the menstruation policy, I didn't see mentioned, and I think it's useful to cite those, the school reentry, and perhaps to include a little synthesis about, even in the activities around work to review some of these policies, because sometimes you do find that they are not always harmonized, and it's important that we have policies that are speaking to each other. The other point is with regards to the activities that are specific to parents and to teachers. And I think it would be good if we were deliberate in mentioning that we would leverage on parents, teachers associations, the Kenya National Union of Teachers, head teachers associations. In some of our previous work with head teachers, they've told us that these are very important bodies and that somehow are not included in our health work. And it would be good to perhaps mention that we would leverage on that. Something that struck me is that there wasn't any mention of COVID-19. And I wonder whether that, yes, this is a living document that will serve for a long time, but I think we've learned so much from COVID-19 that I think it would be useful to include at least some mention of COVID-19 and to reflect on strategies that would help us to be responsive to health or other crises that could negatively affect adolescents, so that we are showing that we are also forward thinking in putting this forward. But thank you. I can share the other comments on the specific activities via email.
Thank you very much, Caroline, for the feedback, and specifically also for mentioning about COVID. I don't know, we didn't quite, I think we didn't quite bring that out. Thank you. I don't see any other hand that's raised. If there's anyone else who has a comment before I hand over back to Sami and Kirago, just in case they have any comment on this. Then,
can I make a very quick one, please?
Who is that?
This is Lisbeth from University of Nairobi.
Okay, no problem.
Yes, I just observed that this forum is not represented by the stakeholders, the beneficiaries who are the adolescents. And what I've seen working in our program, every time we have a stakeholders forum, we have adolescents so that we can listen to them, see whether what we are planning for them is working, and also work together to design things for them so that they take these things up and own them up. That was my quick observation.
Thank you, Lisbeth, for that. The county adolescent health focal points, and then the week of 22nd, we'll have a forum where we will engage adolescents. So we will engage them. It's only we felt bringing them in a forum like this, they may not be able to feel freely express themselves. We want to engage them just as them alone, so that we, even when we are speaking, we speak the language that they understand. That forum is coming. Because in a forum like this, it's quite technical, they may actually get lost. And we are looking at young adolescents 10 to 19. So we'll be having a forum with them. But thank you very much for bringing that out. Any other comments before we move to the next session? Okay, if we don't have any other comments, Sami and Kirago, over to you. I hope now we can hear you. At some point you disappeared. We couldn't hear your voices.
Okay, sorry about that. We'll try and have 2 backups for internet. I think maybe the internet flopped. Well, thanks a lot for the input. I think a lot of them are just for us to go and work and improve on the draft. So we'll take them. There was the mention of whether it's the sexual response or sexual abuse and exploitation response for adolescents has been addressed. There was a bullet that talked about building capacity for service providers who are responding to sexual and gender-based violence. That is under strategic direction 3, but I also think maybe it could also go into the question of access to services. So but we take note of that and we will try and make sure it's better captured. I think other than that, what I was going to respond to is what Dr. Anne have already done pretty well, that in the spirit of meaningful engagement, we thought it's better to have adolescents to have their own day and really come through this. And we'll try and also maybe present them in a more simplified way if necessary. Yes, maybe that's what we can say at this point. Kirago, anything? Okay, I think we are good at that. Maybe we could break into the groups now, Daktari, and allow more input from others.
That's in order.
Thank you. So I'm hoping Kevin is around, just in case of a challenge in doing this. But we've already created the seven rooms, and just hold on, because we are about 35 of us here. That means if we had about 5. Now you realize this is not specific to your area of work. It just gives us an opportunity to go deeply into each of those and try and further review. And yes, you could have a point in an area that you are not included in. So I want to maybe allow me to assign quickly. So I'll just do the first 5 into one group in that order. Dr. Ann, any different opinion?
Oh, okay. We just from the chat box, or sorry, not from the participants list there.
Yes.
Because I thought we could have some representation from like ministry people in every group. I had shared a list of the participants with the organization. I had shared with you.
Yes.
I don't know if you've seen it.
Yes, we've seen it.
So that like we have quite a number of people here from the same organization. We have DSW has quite a number of people, Plan International, UNICEF, and JPEGO. So I thought they should be put in different, maybe just have them in different groups. As they are doing that, anyone with a comment? Anything?
Representing are the ones who determine.
Oh, you are talking of the adolescent engagement we are going to have with them.
Yes, yes.
We are doing that through the children's department.
Okay. Are university students represented there in children's department?
No, because I don't think
we have university students from 16 years to 19 years.
You have university students who are 16.
Yeah, to 19.
We are working with the Department of Children's Services. They have an already existing children's, what did Sammy call it? Sammy, can you try and answer that question? Tell us, what was that name of that already existing? Or Susan? Susan, can you? Susan?
The Children's Parliament.
The Children's Parliament.
Okay. So probably you can also answer whether the university students are represented. Why I'm asking this, we have a lot of issues that we are trying to iron out there. Some come to universities when they are so green, some are mentally depressed, some are getting into alcohol abuse, some are getting into SGBV issues. They are too young and people seem to think they are privileged, and they are not privileged. They don't know anything. Yeah. So are they left out?
Sorry, if I try and respond to the question of the university students.
Yeah.
Well, what I know is from the Children's Parliament has been, I mean, it's been largely up to 18 or 17.
Okay.
So it's not, I mean, most of that age will not be in the university.
Yes.
So I think if there are other platforms, because I remember during the stakeholder consultation meeting, the other thing we agreed on is if there are other platforms that you already do have, we could, as consultants, provide a tool if you can help us pull through before the 25th of this month and use existing platform. So that I think we were open to that. Dr. Anne, you can correct, but the Children's Parliament will not necessarily be having university students. So if there are other platforms, I think we'll be more than open.
But they can be very effective in mobilizing these other children.
I think one of the reasons we decided to use the Children's Parliament is because of the already existing mechanism for engaging them. So that's why we are using that platform. We plan to have maybe between 20 or 15 to 25, let me call them adolescents in the forum. So that's why we were using that, because it's already an existing mechanism. It will help, we'll be able to mobilize, we'll be able to bring them. Don't forget that those below the age of 18 have to be brought in with the chaperones, because they are not considered adults to like travel if they're traveling from on their own. So we want to use an existing mechanism. We didn't want to just have, that's basically why we focused on using that. If there's an existing mechanism where we can get feedback from the university students, as Sammy has put it, we would be more than willing to get that feedback. It's only that maybe also in our mind, we did not think, we hadn't thought of getting the engagement directly from the universities and colleges.
I understand.
Sammy, you are ready to put us in groups now?
Okay, I will assign. Hi, Dr. Ari. I was consulting with the IT person, so I think we'll have to do it manually. That way, then we get the balance. Maybe then what we can do is I will have Beatrice to go to, we are not very many, so I can quickly do this. Can I have Beatrice and Beatrice Ochieng, Beth Kangwana, and 2. Beth, you can always say if you prefer any other, but at this point, really, it's not linked to what you do daily. Caroline, under 3. So I think as I'm doing it, it's moving. Christine Karanja, under 4. Christine McKenna, 5. Christine Wambugu, 7. Collins, 6. Dr. Anne, 1. Okay. Oh, hold on. Elsa, I'll begin from 1 again. Francis, Kadiri, 2. Jennifer, 3. Judith Raburu, 4. Judy Amina, 5. Kemunto, 6. Lisbeth, 7. Okay. Oscar, number 2. Salima, number 3. Stacy, number 4. Teresa Loire, number 5. Veronica, number 6. Number 7. Solomon. No. I believe we are all assigned.
Some of us are still here.
I know.
Or we have not gone. I thought we should go when we are assigned.
Yes, you. Where do I put you? 1 or 7?
Wherever. I have no problem. Wherever you put me.
Okay. Since I put Christina number 7, I'll put you under 1. Florence, you're a data person. Huh? Kuna wengine? Naona siyaona.
I think they have to answer.
Hello, Michael. Can I please request to be moved to room 6?
Can I text to this number?
Hello. Hi, Beth.
Hi, Michael. I was wondering if I could please move to group 6.
We have very few people in that group. We just have 2 people. So we ask you to please just participate there. We can have a specific session with you where you give us feedback for SD6 if it's your area of expertise. Hello? Yes.
participate in advocacy, in collaboration with counties, define minimum standards for adolescent participation and inclusion in policy, financing, and program implementation, interlink and build capacity for existing toll-free telephone helplines, which they've given, to comprehensively address adolescent health issues, identify and promote key social influences as champions for adolescents' health and educate adolescents on their health rights, promote the role of adolescents within the community health strategy to engage older adolescents as community health volunteers and community health committees, collaborate with the Ministry of Education to review and enhance the health information in existing education curricula, socioeconomic empowerment, example, business or vocational skills, such as training, productive cash and/or in-kind grants, some of which will be made conditional on delayed marriage and access to financial assets or services. So that's what there is.
We're too close. I don't know whether you peaks media need. I don't know whether in the whole document I found the discussion had really advanced. Does it let me use categorize the me are largely I can tell you here social media coverage for this. Be a little bit for youth. We are even network coverage for our big Safaricom Airtel is not very sufficient. So that categorization for me, social media might not work in all those different categories of adolescents and young people that we seek to serve. And therefore we need to have more strategic approaches with considerations to the categorizations. Secondly, there is documented evidence again on effectiveness of peer-based programming. I think I have a document. The document is titled What Works and What Does Not Work for Youth Interventions or for Adolescent Sexual Reproductive Health Interventions. And peer education has been identified as one of those strategies that do not work or do not achieve much impact. So, and I'm seeing a lot of mention here on nationwide peer education programs, established peer-led groups, and those ones are really, they are not, they are based on scientific evidence. They are not achieving any impact. Let me pause there for now and hear our other opinions.
I think those are 2 points that I completely agree with. Maybe just to add to your first point, so in terms of the areas you work in that you mentioned, like Turkana and so on, in most instances, those are the most vulnerable populations of adolescents. So I completely agree that more thinking needs to be done in terms of how to reach these adolescents beyond social media, since they don't have access to these to this. In addition to that, they had mentioned the interlink and build capacity of existing toll-free telephone helplines. So from my experience, again, I've worked in places like Wajir, and even, if you go to some urban areas, the young adolescents don't have access to phones. So, again, thinking beyond telephone helplines, how else can these adolescents
Sam, can you hear me? Sam. Sam.
Yes, I can hear you.
You know, in the group, it's like I'm alone. I can't even hear people responding to me. I can.
Kemunto. Kemunto. Ah.
Kemunto.
I'm actually trying to. I'm trying to reach the person so that they will join.
Okay, I see. Let me. Yeah, I can see you're alone. You know, we had assigned more people to your group.
I think I don't know if they have dropped off, because when you assigned immediately, I saw like 4 of us. I don't know if they have run away and joined other groups or.
This is group 6, isn't it?
Yeah.
I don't know, because I see you're just with Kemunto. I don't know why she's not active. What do we do? I think you just try.
I think maybe you take me to another group.
But group 6 is very critical. Okay, do you have the whatever it's called?
I cannot work alone.
No, you are umetosha.
No, I cannot. I'm so many other things on the sides, behind the scenes. So I really need this team to be here. Or you pull other people from other groups. Which group has several people here? Kemunto?
Yeah.
You can hear us?
Yeah, now I can hear because I've been waiting until I decided to change location. I thought I was not catching you because of network.
Okay, so we need to start. Sam?
Okay.
Yes.
Did you share by that presentation?
Should I email it to you or something? Because I tried putting it on that chat for everyone.
Yeah, you could kindly email.
Okay, that one.
Kemunto?
Yeah.
You can see the task that is ahead of us, what we are expected to do in the chat for group 6.
There's a chat here. I can't see any chat.
Okay, it's on data.
Oh.
So there's a question for us here.
Let me go and open my laptop then. I can check through it.
Sam,
I have resent it again. I've sent to Kemunto directly.
And how about me?
It's also there for you. Okay, let me resend it to you. But I'm sending the PowerPoint to you also. Monte, did you succeed in seeing the document?
Sam, are there people who are hanging that have not joined any group?
Hi, Florence.
Yes, Sam.
Any progress?
Yeah.
Progress? Emunto?
I can't seem to get anyone, so maybe I'll just see what I can do.
Yeah, just can't.
Kemunto?
Yeah.
Okay.
Kemunto is there?
Kemunto is there. Kemunto, just chat here.
Oh.
Send me a chat with your email address. I can send you the PowerPoint in case you're not having it. Do you have the original document?
Yeah.
Okay, so then you can just make reference. So the idea is to scan through that, and like it says here, you've seen the instructions on the chat. So
Yeah, I
review
saw
this.
what you said.
Okay. If you don't mind, because I'm roaming, you can converse with Florence. I'll need to check on other groups.
It's okay, Sam.
Hi. Thank you.
Let me put the group 2, group 5.
Yeah, group 5.
What was the name? Community
advocacy, something about.
Let me copy it from document. Oh, we have a third member joining us.
Hi, this is Samuel.
Samuel is here.
I'm just, you guys are doing fine, I see. Thank you.
I think we are done.
Okay.
Yeah, we're actually done.
Good. Okay. So put it in
So-
there and you can share. Thank you.
All right.
Hello.
Hello.
Hi, Elsa and Dr. Ann. You're finished?
We are through.
Okay, so you can join the main group so that then maybe in 2 minutes I can close this.
Okay.
Thank you.
Can you see what I've highlighted?
Okay. Develop and implement national tax shifting strategy where health facility staff build capacity of adolescents in certain aspects of health service provision. Okay. Yeah. Where health service build capacity of adolescents. Okay. So that it means that we want adolescents to maybe peer, the concept of peer, some form of service delivery is done by adolescents themselves. That's what it means.
Hi, Stacy.
I'm saying the way I've understood the point.
Okay, are you guys almost done?
No.
10 more minutes.
Are we
please.
almost done? 10. Okay.
Okay, can we try like in another 5? Because most people have finished.
Okay.
Okay. And then remember to save your document. I see it says read only.
Yeah, I shall save it.
Okay, thank you. Okay.
Yeah.
Okay, so sorry, Leila, you were saying something, I missed it.
Hi, Dr. Christine.
Hi.
I see you are wrapping up.
Yes. I was just saving the document with the comments so that I can share it on email.
Thank you. Okay, then I think you can also come back to the main room.
How do you come back? You leave the room.
Yes, you leave the breakout room, not the meeting. Yeah.
Okay. Okay, thank you so much, Lisbeth and Wambui. I think it has been an exciting time.
So welcome back, everyone. I see all groups, everyone is back. Please make sure you send your feedback to your groups. I've received a couple of them. From group 7, group 5, group 3. So what might be useful right now might be at least one person. Let's have one person from each group, just giving some high-level comment, your overall views on the strategic direction. The detailed reviews, I know people will still send them in, and feel free even beyond this meeting to send an email with detailed feedback on the draft, so that as we continue working on it, it's also incorporated. So let's start with group 1. And unfortunately, a couple of people left at the time when we assigned groups, so we apologize for that. Some of you may have found yourself fewer than we had anticipated within the groups, but it is what it is. So let's get one person from group 1, just giving a high-level comment on what you think in the strategic direction, and as we await your detailed review.
Okay, thank you so much. Again, group 1 was myself, Elsa Odira, and Dr. Anne Mwangi, head dash. We had 8 objectives to look at, and when we looked at them, there are some we felt were beyond the division's mandate. There were others we amended, and there are some which we might need another division to look at. Now, there was a point, since now Dr. Mwangi has not shared, but I can just talk verbatim of what we discussed and what we felt. But if you have the document, you can look at it on objective 1. So there's a point there which was talking about advocating for continuity of education to adolescents. So there it had advocate for legislation on, okay, she's sharing. Okay, thank you, Doc. Let me see this, governance 1. Implementation of existing policies and whatever. The first bullet, we actually left it the way it was, the strategic objective. Okay. The second one, advocate for development of an implementation of health financing mechanisms and access to health services. We added UHC there. UHC was already in the document. Okay. Advocate for investment in status intervention support school enrollment. We added school enrollment, retention, and return. We added the word return. You remember very well the policy direction, which if a girl gets pregnant, then they can go back to school. So we added the word return. Then develop and implement legal frameworks for regulate marketing of unhealthy foods and sugar sweetened beverages. We highlighted the word sweetened beverages to be looked at by the Division of Nutrition, because we know it's not only sweetened beverages that matter to the health of the adolescents, but even also some other beverages which are unhealthy. So we want the nutrition section to look at that point. Develop comprehensive legislation for indoor pollution and environment. We thought this is not within the mandate of the Division of Adolescent Health, and it would fit better. So we highlighted it red for possible deletion. This section falls under Ministry of Environment, Ministry of Housing, NEMA. So the Division of Adolescent Health may not execute this. Okay. Advocate for commitment on implementation of mental health. We struck out, we are thinking strategy. Strategy is not the right word there. We want to interventions, to have the word interventions targeting adolescents at the facility and community. So we propose the word interventions other than strategy. Advocate for social protection of adolescents. Okay, all that area. Then we said social protection of vulnerable adolescents. What we want to talk there are issues of having adolescents access. You remember the monthly stipends that WASES get, the vulnerable adolescents and special adolescents, disabled adolescents can be considered for that. Develop policies and guidelines to this intentional parenting. This is not within the division. So we highlighted it red for possible deletion if it is agreeable with the larger group. Thank you.
Thank you very much for your feedback. It is well taken. It's a working document. We will continue to enrich it and consult people, like where you've suggested we consult other divisions. We're going to consult and make sure that we have the right wording. So thank you for that feedback. Please make sure you send it in so that we make sure that it's all incorporated. Group 2, could we have a member of group 2, please?
Dr. Kirago?
Yes.
My name is Wamboi. I had an issue on strategic direction 1.
Okay.
Point number 3, the strategic activities.
Go ahead and give it.
Yes, I was thinking this issue is already taken care of so heavily by the Ministry of Education and the Ministry of Interior. I think we'll be duplicating efforts. They are doing so much on this point. From my view, we don't have to do this.
Okay, that point is taken. Thank you, Wamboi.
I have a question on that.
Yes.
This is Teresa. Hello, may I go?
Yes, go ahead.
Okay. I know that there's a lot of investment on school enrollment and retention, but do we know how well it's working for adolescents with chronic illnesses or pregnant mothers? I know there's a lot of investment already going on, but my question is, do we have any information on adolescents who are living with a health problem or a health issue? Over.
Dr. Ann, do you want to respond to that? Adolescents with NCDs, things like diabetes, yeah, chronic diseases. Dr. Anne, do you want to respond to this probably?
Okay, I think in my opinion, it would still be okay to have the activity. I think someone said we make them strategic interventions. I think we would still keep the intervention, but definitely the division works a lot with the Ministry of Education. I don't think we've reached where we would want to see ourselves in terms of ensuring that there's 100% retention, transition, and even issues around re-entry, especially for those who drop out for various reasons. So for me, I would still say we can retain this, especially also considering the fact that we are working very closely with the Ministry of Education, and a lot of our adolescents are still in school. A lot of them, actually, majority of the population we are going to be targeting with this strategy is in school. So it's okay to have the intervention in the document. We can't completely strike it out of the document. It's part of what we are doing. It's an ongoing process. So I would say we keep the intervention. Thank you. And I can see, I don't know, I can see Dr. Caroline Kabiro has her hand up. I don't know if she wanted to mention. Dr. Kabiro, did you want to comment on SD1?
I think you've touched on it, because I was also wondering, given that there are big significant issues around school reentry for pregnant and parenting adolescents, I think it would be remiss for the adolescent health team not to be involved. But I think you've captured it. Thank you.
Okay, thank you.
Thank you.
Thank you, everyone. We are capturing all your feedback, and we would ask you at this point, just give us a feedback. There are more deliberations that are going to come up, but in the interest of time, just give us the feedback. We'll go back and work on it, consult whoever needs to be consulted. And we also have, the co-writing team that is supporting with the decision. So feel free to just write and even email it in, whatever feedback you have, it is going to be considered. So thank you for all those who made the contributions. But in the interest of time, I ask that we move on, just get high-level feedback from each group, send in your written submissions for consideration, and there will be another point which will be engaged. I know Dr. Anne will talk about it. There will be another session for us to make our inputs once again and see whether what we had proposed has been included comprehensively. So let's have someone from group 2.
This is Oscar Kadenge. I'll speak on behalf of group 2. We did look at this SD2 and we said, one, under the context, that it is important for us to broaden it so that it speaks to the different cadres of youth, those that are tech savvy and those that are not, those that are within the rural regions also need to be addressed so that in terms of the context, regional disparities need to be covered, with the focus being on equity being brought out here. Then peer education approaches, I think we said, have been found to be ineffective, and I think we need to rethink the approach in that particular regard. Under the strategies, we did mention that there would be need to have capacity building efforts that support the development of what we would call a culturally contextual life skills and livelihood training program for adolescents, especially those that are within the ASAL and emergency prone areas. Also look at adolescents being trained on budget advocacy so that they can ably participate in decision making, especially at the level where we have, budgets being drawn up and so on. Then in terms of curriculum development efforts, we said that we need to incorporate statutory bodies such as the KICD, TSC, etc., so as to make it possible to secure buy-in and also address any potential barriers to uptake, such as been faced, what has been faced within the introduction of the sex education programs. And then we also need to look at the toll-free lines. We need to look at the toll-free lines and say that not all adolescents have access to these phones. And then also look at alternative platforms, e.g. the child protection systems, the whistleblower systems that we have at the county level. There's also need to consider existing platforms such as those that are within the MOE, like the life skills, education lessons, school health committees, guidance and counseling units to provide opportunities for youth to be engaged in them. Strengthen also intersectoral linkages that build off socioeconomic empowerment platforms such as the Kenya Youth Empowerment Program, which I think is one area that we need to speak to. Area advisory councils also provide an opportunity to have youth involved in decision making from the grassroots upwards. And then also undertake a resource mapping, what existing platforms that are there that address adolescents, such as the DREAMS project, a program which essentially is having an impact. And then also the community health strategy provides us with an opportunity to have a policy statement around the recruitment of say out of every 10 CHVs that are recruited, we could have 2 adolescents and have these 2 also become members of the community health unit. These are just the highlights of what we discussed, and I would invite Beth or anyone else in the team to add, Francis, if you're on the call.
Thank you, Oscar. Any additions from the group members?
I think
Nothing
Oscar
to
has ably captured what we discussed as a team. Thank you.
Thank you, Group 2, for that detailed feedback. Please ensure that you email that back for incorporation. Group 3.
Thank you. I'll present on behalf of Jennifer Wangui, Salima Mohammed, and myself. Overall, we felt that the strategic direction 3 section was well written. For the very last bullet, we thought it would be good that speaks to adolescent health broadly and not just mental health. But in terms of additional strategies that could be employed, we spoke about leveraging on parents, teachers associations, NAT, CUPET, when building the capacity of teachers and parents. Then developing teachers and parents manuals that cover content on sexuality, sexual and reproductive health, psychosocial counseling, SGBV, reporting mechanisms, addressing mental health and bullying, menstrual hygiene, and then explore options to make the teacher's manual part of the teacher training curriculum. We also spoke about developing radio lessons to complement the training of teachers and parents. Then we spoke about building the capacity of community health workers and other young people who can mentor or support adolescents in instances where adolescents are not comfortable speaking with parents and teachers. And that should be linked to strategy 7, which is about strengthening community health committees. In terms of the 4th bullet, we said there's a need to build the capacity of all duty bearers, not just the Department of Children's Services, on the identification and referral for psychological support services. And then for all capacity building activities, we felt it's important to create platforms where those who've received training can discuss progress and say challenges that are related to implementing specific activities related to the knowledge and skills that have been gained through the capacity building initiatives. I don't know if Jennifer or Salima have anything to add, but that's it from us. Thanks.
Thank you. I think that captures everything we discussed.
Thank you.
Thank you, Group 3. Thank you, Group 3, for that review. Once again, please ensure you submit that through email so that we can incorporate your feedback. We can move on to Group 4. We have Stacy and team.
I'll present on behalf of Group 4, which was with Judith, Leila, and Christine. For the strategic direction, it's just a matter of editing that we noted. Concerning the context, our issue was on stating that health workers do not have capacity. From the discussions that we had, the conclusion was that the situation is not that they don't have capacity, but there's limited capacity within the country. On the strategic activities or interventions, concerning the first one, our recommendation would be to first include focused protocols and training packages that is all inclusive, not just targeting vulnerable adolescents, but adolescents in general. Then there's a point that says that and adolescents in emergency situations. So part of the discussions was, should we separate emergency situations and just have a different strategic direction that focuses on emergency situations and adolescents? Because it's very vast and cannot be limited within the strategic direction 4. Then the other one is on bullet 3, to have to specify on having this done in all levels of care to ensure accessibility. Also acknowledging the point that was brought about by Dr. Chiza concerning the approach of having adolescent service provision in the service delivery, not just centers. Then bullet 1, 2, 3, 4, 5, 6 on the development and implementation of a national task shifting strategy where health facility staff build capacity of adolescents. We said that there's need to bring clarity to this point, especially in terms of definition of the health service provision that could be taken up by adolescents. Then to address the point on the financial limitations by adolescents, we could also include interventions on defining and advocating for services that could be covered under UHC. That's it, over.
Thank you, Group 4. Your team members, do they have anything to add? I guess not. We can move to Group 5.
Okay, I'll present on behalf of Group 5. This was done together with Teresa Alua. And so our main points for the strategic direction 5, which is that to sustain community advocacy and engagement for collective support and protection of adolescents. On the goal, we felt that the bit on the program should be removed. And this is because programs are sometimes limited. It could be limited to time, could be limited to a number of places. So we thought it would just read enhance community engagement in adolescent health generally by drawing from its own resources and mitigate against social cultural factors that affect adolescents in Kenya. And then for the context, we feel that it reads well and it acknowledges that the community do have resources that can be used to facilitate implementation of the strategic activities that have been identified. On the strategic activities, the first one on the grassroots community engagement with targeting messaging, we felt that instead of targeting the community with already messages that we've created, what we want to do is empower the communities with information for them to identify the specific challenges that are there in adolescent health, and then for them to come up with the strategies themselves that are homegrown and that are cater to their own needs. And then for the strategic activity 2, strategic activity 2, 5, and 7, we felt that we could match them because they're all speaking about engagement of adolescents and young people as youth champions, as champions mostly in engagement of adolescent health. And then for strategic activity 3, we felt that when we mention duty bearers, we also need to define who they are. We actually need to identify who are the duty bearers in these communities, who are they accountable to, and how can we reach them so that we have proper mechanisms of reaching out to these duty bearers and making sure that they are accountable to what they had already promised or set up to do. And then on strategic objective 4, here we also need unpacking of the vision of safety, because we see that we've mentioned a few things on promoting safety and security for adolescents by collaborating with security agencies. And here we've mentioned discipline issues, drug abuse, keeping people safe, SGBV, away from violence, and other manifestations of ill health. So when it comes to mental ill health, we need to unpack what exactly that is, and maybe just being more exhaustive and particular on this, on the issues that we've already identified. On strategic objective 6, the collaboration with the media practitioners. First of all, because we know sometimes the media does not always have the information or the knowledge that is needed on the different topics that we are addressing. So specifically on adolescent health, one of some things that you could do is build the capacity of media practitioners to accurately report on adolescent health related issues. And then when you're talking about adolescent health, maybe we can make it more general, aside apart from adolescent sexuality, adolescent reproductive health, just identify the different areas of adolescent health that we actually want to focus on. I think for us, that was it.
Thank you very much for your feedback. Group members, do you have anything to add?
No, I think Judy has captured it well.
Thank you. We can move on to the next group, group number 6. Florence or Kemunto?
Yeah, so for group number 6, I was with Kemunto, and we felt that the goal was okay, but the context is a bit wide. If maybe statement 1 and the last one could be merged to be one. For the activities, we went through them, they are all fine. But for the additional questions that we were given to respond to on our overall comment, there is need for, there are several institutions that are implementing adolescent health, but no standard reporting mechanism. So if that could be put in place. And then the other thing was on any additional data that will be collected. So we thought of a number of adolescent learners that are dropping out of school, the teen pregnancies, number of teen pregnancies, adolescents that are undergoing labor or unskilled labor, and then on data that is unavailable and that should be collected, we thought of adolescents that are undergoing FGM or female genital mutilation, teen abortions. I don't know if there's ever been data on that, on teen abortions or marriages. Then there's the issue of WASH issues, institutions that are handling adolescents but without water, without sanitary facilities, or maybe even adolescents that are dropping out because of lack of, the sanitaries that adolescent girls use. Then adolescents who are orphaned, with the caretakers. And there's also we would also wish to see data on adolescents who cannot access platforms when they are out of school. With that can to air their, that was it. We will share our final presentation in a few minutes.
Thank you, Florence. Anything to add from your team members?
Kemunto?
Nothing more to add.
Thank you. Group 7.
Thank you. I will present on behalf of the group, but Christine will share the screen.
Okay, I cannot share as long as Dr. Kiragu is sharing. So.
Hello?
Kindly stop sharing the previous.
We've enabled.
Okay, thank you.
Okay.
Try increasing the size, Christine. Okay, thank you. We felt the goal and the context were well captured. We just had additions on the activities. And the first thing we looked at was the issue of operationalizing a national adolescent health technical working group. We felt because the TWGs are already there, we talked about strengthening them, not operationalizing. Then we had an addition on that first point on the TWGs. Christine, can we share the comments? So on the issue of monitoring, we were wondering whether the point should be in SD7 or in SD6, where there is data and monitoring. But we shared the issue of what is happening with the ICPD 25 national commitments and how a technical working group has developed indicators and is meeting annually to report on these indicators so that a national report is developed, and how they have even gone a step further and put in a module in the electronic national integrated monitoring and evaluation system. And now the report will be generated automatically when the different implementing partners report in the module. Okay, back to the other side, Christine. Thanks. Then we had an addition, conduct mapping of adolescents in and out of school and college for purposes of adolescent reorientation and participation in the National Adolescent Health TWG. And we thought particularly those who are 18 and 19 years who would be able to participate actively. Then for the issue of conducting donor and NGO mapping, we thought we should add target population, we should conduct, as we conduct that, we should look at the target populations for these NGOs. Then we had an addition to harmonize the different efforts and interventions to avoid duplication and maximize on resources. And then when it came to the county TWGs, we felt we also need to go further down and add sub-county and facility levels. And then from there, we had an additional point of, as we had in the national level, conducting mapping of adolescents in and out of school and college for purposes of adolescent pre-orientation and participation in the county, sub-county, and facility adolescent health TWG. And as we said earlier, particularly those who are 18 and 19 years, who would add value to the forums. Then we talked about the issue of community health committees, and we thought we needed to be clear where they will be located, who they report to, and who will be in charge of these committees. And we added that they should be working with and reporting to the Adolescent Health Facility, TWG, so that their issues are scaled upwards. Then on optimizing the public-private coordination, collaboration, and accountability for adolescent health, we had some additions. We thought we should add work with media advertising and hospitality industry to advocate for healthy, nutritious foods and avoid marketing of high-calorie foods and drinks, alcohol and cigarettes to adolescents. We felt the way that point was coming out negatively, like we were trying to advocate for this negative or high-calorie foods and alcohol and cigarettes. So we thought we need to tweak out that point. And then for the second point, improve adolescent healthcare services within the private sector by engaging the private sector in the national, county, sub-county, and facility TWGs and capacity building them on quality adolescent-friendly services. Then we had another addition to map out the private companies, private facilities, health facilities, private institutions, and private individuals who we can work with and collaborate with on adolescent health. That was what we were able to do.
Thank you very much for your feedback. Is there any addition from your group members?
It's fine. I haven't really.
I don't have anything else to add.
Thank you very much. Group 7, please also, I think we already have yours. So thank you very much, everyone, for the conversations. Thank you for your feedback. As I said, feel free to shoot an email if something else comes up, or even in the course of your work, if you find opportunities to improve this document, we can continue to improve it. So at this point, I'll take it back to Dr. Ann. But before then, maybe Dr. Mkatha, one of our team members who is here. You can introduce, say hi to everyone else. Yeah, it may be not possible to do your presentation, but.
Okay, thank you, Dr. Kiragu. Good afternoon, everyone. As Kiragu has said, my name is Mkatha Morongi. I'm part of the team that is developing the strategy. I was unfortunately not able to join you earlier because of another commitment, and I was also supposed to make a presentation, which unfortunately, because of the time, we have decided to rather just let it go. But I'm glad I've been able to sit through some of the discussions that are going on, and I appreciate your time. So from my side, it's really a word of thank you. Thank you for your contribution. And we look forward to receiving the more detailed ones that you have from your meetings. Thanks, Kiran.
Over to you, Dr. Anne.
Thank you very much, Kiran, for facilitating the sessions very well. And we have come to the end of our meeting. I'm sorry, I promised we would finish before 12, but it looks like we just couldn't manage that. So just forgive us, and yeah, so that we move forward. We have a few next steps just to let us know what we plan to do in the next couple of weeks. One is that, like I mentioned earlier, we have planned for a county engagement forum tomorrow with the adolescent focal persons. We'll be having it virtually around the same time, 9 to 12 p.m. And afterwards, we'll be having the consultants continue in the incorporation of the feedback they have received from today's meeting and tomorrow's meeting. That is if it's feedback that doesn't require the larger team. Definitely, if there is feedback that will require the writing team, we'll work with them during a planned workshop that we plan to have for 3 days. It will be between 15th and 17th of March. That's the week of next week. And during this workshop, we kind of finalize everything, the feedback from the 2 workshops and any other feedback that we may receive from you in the course of this week and next week. Kindly feel free to share any feedback that you may have, even if probably it didn't come out today. We are still open to your feedback. We are open to your suggestions. So if you put them in writing and send them to me, I'll be able to share with the team during the writing workshop. As I mentioned also, we'll be engaging the Children's Parliament of 22nd. And the reason we could not bring this before the finalization workshop is because of the timing, because we still have to allow for planning to engage them, but we'll definitely incorporate the feedback we'll get from them, even if this comes after the workshop. Then after that, we will have a virtual or physical validation workshop. And this really will depend on availability of resources, whether we'll be able to hold a physical meeting for the validation. I think we should hold a physical meeting. I think it would be good to meet people, especially if we can be able to get a hotel where we can observe all the health and safety measures. And our proposal is any day, either 25th or 26th of this month. And that validation workshop will kind of be the last activity. And the rest will be finalized by the consultant, and they should hand us a document that's final before the end of the month of March. As I mentioned, our funding is coming from Afya Halisi, and their project is closing by the end of the month. So we are really working with very tight timelines such that if any activity is moved, we almost have no time to adjust for it. So the next steps that will follow is editing, design, and layout approvals by the Ministry of Health, and then printing, and the next one should be launching. All these activities, which are quite tail-end activities that do not require the consultant, will probably be happening in the month of April. So that is basically how we plan to do this, and we'll definitely engage you and involve you in the remaining work. There are those of us we might invite for the finalization workshop. There are those, if you would like to participate in, when we are engaging the children, we may not want a lot of people, but if you're very good in getting information from children and you would like to, probably your organization would be able to sponsor you to join us because it will be a physical meeting. We'll definitely appreciate 2 or 3 other people joining us if they are available for that children adolescent engagement forum. It will be in, it's likely to be at the river, so it will not be so far away from Nairobi. So basically those are the next steps. And once again, to just say thank you very much for joining and also for staying in to the very end. I know there are those who joined and were not able to stay in, and we're also very grateful that they were able to join. There are those who joined us after we had done the introductions, and so we may not know which organizations they are coming from. And I would like to ask Oscar, just for us to know where you're coming from, Oscar and Salim.
Dr. Ann.
Salima. Yes.
Dr. Ann, if I may ask, are you able to share those way forward probably in a written format?
Yes. I can send an email.
Okay, fine, thanks.
Yeah, we have Oscar and Salima Mohammed. You can quickly introduce yourself and tell us the organization you're coming from. Salima and Oscar, just tell us where you're coming from.
Salima Mohammed from Mary Stops, Kenya.
Okay, thank you, Salima. Oscar? Okay, maybe Oscar is not able to hear me. So I think the next steps in our agenda for the day is to have Dr. Christine Wambogo, who is the Adolescent Health Program Manager, giving a vote of thanks. And then after that, we'll close with a word of prayer. Dr. Christine?
Okay, thank you so much, Dr. Ann. I'd like to thank everyone for their active participation. You've really enriched the document, which was the ideal reason why we were having this validation meeting. So I think we're looking forward to consolidating all of your comments and having a very rich document which is going to address all the adolescent health issues. I'd like to specifically thank those who have stayed on up to the end, the MOH staff, Amasi Karanja from the Division of Mental Health, Dr. Gladwell from NCDs, Veronica, who's the head of the Nutrition and Dietetics Unit, Elsa Odira, who's from our sister division of Child Health. I'd like to thank the team from UNICEF, Judith, Dr. Teresa, Stacy, and Laura, and also participation from the other UN body, the World Food Programme. I'd like to thank participation from University of Nairobi, that was being led by Lisbeth, NCPD, Wamboi Kungu, and the Kenya Pediatric Association, Dr. Christine Chege. We saw her in her scrubs. I know she's very busy, but we are really grateful that you had time to participate in this forum. I'd like to thank the other implementing partners who are with us here, Plan Kenya, Population Council, DSW led by Evelyn Samba, APHRC led by Carol Kabiru, EGPAF was represented by Job, the Center for the Study of Adolescence, Save the Children, LVCT. I know John was here, although he came in a bit late and was not able to introduce himself. Oscar Kadenge, who has also been instrumental in giving his comments, who's from PATH. Would like to, last but not least, thank most profusely Afia Halisi for helping us to finalize the strategy. It's been a long time coming. Our sincere thanks go to Solomon Orero and Daniel Were, Susan Ontiri, and Florence Akinyi, who've worked tirelessly to ensure that all these processes have been involved. I'd also like to thank the AICS team, led by Samuel, together with Michael and Katha. We really thank you so much for your invaluable consultancy that has helped us to put this together. And last but not least, I'd like to thank our team from the office, led by led by Dr. Ann Mwangi, who has been really instrumental in unsticking this process from where it had been, despite all the challenges of COVID. We are really grateful for that leadership. We want to thank also Beatrice, who's our focal M&E person, and Alex, who's our school health focal person, and our auxiliary staff, John, who's from Evidence Action, who's not with us in the meeting, but we really are grateful for their participation, and Petronila as well, who we work together in the office. So that being said, I just want to hand over the program back to Dr. Ann Mwangi to close the meeting for us, and sincerely thank everyone for their participation. Thanks again.
Yeah, thank you very much, Dr. Christine, for that vote of thanks. And once again, thank you everyone for joining, for staying on. If you have any comments or any queries in the finalization process, kindly do not fail to reach out to me or Dr. Christine, and we'll be able to address that as much as we can. So thank you very much. It's now 12:30. I kindly request someone to pray for us, and then we end the meeting. And as we end the meeting, there is a court, you know yourself, Dr. Christine, the team from the team from the Division of Adolescent and School Health who are here, the team from Afya Halisi and the consultants. Kindly, as the others leave, let's remain behind for about 15 minutes. Thank you. Anyone who can lead us in a word of prayer, please?
Yes, Dr. Ann.
Okay, thank you, kindly.
Okay, let us pray. Heavenly Father, we just humble ourselves before you because we invited you to start this meeting with us, and you have been with us, Father, throughout the process. You have guided us, you have inspired us, and you have energized us. Father, as we stop this meeting, we pray that you're going to continue being with us, Father, even in the next steps, Father, that are going to be going towards implementing and finalizing this process. We pray that, Father, you're going to give us your blessings and your guidance, and that you're going to protect and bless each and every one of us, Father, in this forum. In Jesus' name we pray. Amen.
Amen. Thank you very much, everyone. And we will call you again and again. You are part of us, and we will always call you when we are doing this. And for the next steps, I'll also share in an email. And if we have any resource gaps, I'm looking at the validation meeting that's likely to be a physical meeting. I really hope it can be. I probably will just float and see whether someone is able to support our meeting in Nairobi, a conference package. Thank you very much. We wish you a good day and a nice week ahead. So the rest of the team can leave as we are left with the core team. Yeah.
Thank you and bye.
Bye.
Bye-bye.
Bye.
Bye. Hi, everyone. I think we have just the 8 of us here. I can see Kevin, Florence, Michael, Sammy, Christine, and Kala. So I will just open the floor for I know Dr. Kirago wanted this meeting to be at 4, but I have another engagement at 4 p.m. and actually starting at 3 p.m. So I didn't want to push it. I think it shouldn't take long. It's just a quick postmortem of the meeting that we just had, and probably what we can improve on tomorrow. I think we can raise those issues. Probably some of them could be technical issues and others could be in terms of time management. So maybe we can do that quickly. We shouldn't take long. We should be done by latest 10 minutes or 5 minutes to 1, so that I allow you to have your lunch. So the floor is open. We can even put on our cameras and unmute ourselves and just speak.
Thank you. Actually, I have another meeting that I requested to postpone to 12:45. So, but just two things. One, thanks for the support from the team. I don't know. I think we were all cooking, so we can give feedback on whether the salt was enough. I think it went well, in my opinion. Of course, there are those group dynamics, knowing how to manage it better. And we thought this would be important to carry forth to tomorrow. So if it was possible to have the people register earlier on, and then we know who they are and we group them earlier, that would work. But thinking about tomorrow's, have we received any feedback from using the tool we gave? because that will be a bit different. I'm not sure whether the county teams have read this document and whether it will be useful to even take them through the strategic activities as they are. So for me, I think those will be the things to consider as we think about tomorrow. Kiragu, any thoughts?
Yeah.
Maybe before Dr. Kirago speaks, I spoke with Mabel, the focal point that we were given at the Council of Governors, and she doesn't think the team need to register in advance. She says it is hectic, it is going to bother them, and she just said no. So for her, the team will come in and they will start the meeting, and then we proceed. So she shared with them the link for the feedback. She shared with them the document, but I wasn't included in the mailing list. So I am not, my communication is only directed to her. I'm not in the communication that she sends out to the counties. So in terms of whether she's receiving any feedback from them, unless I ask, I don't have that. But I think just like today, my proposal would be that we still allow them time to give us feedback on the sections. They may not have read the whole document, but just like the way we were able to focus on strategic directions and allow people to digest them in groups, I think it would still be a good idea, because in a group, people are able to focus on that particular one. If they didn't focus on the others, they will probably be able to give feedback on the particular objective direction that they have been given. That's what I would propose. Thank you.
Was there a sense of the numbers of people who we should expect? Because that was a challenge today, considering that some groups had 2 people, 1 person. I mean, that's challenging. So now without a pre-registration, it sounds a bit tricky. Maybe we may have to have fewer groups so that maybe we sort of try and manage the numbers. Maybe have 3 groups that handle maybe 2 strategic directions at a time. I don't know what you think.
Yeah, I agree in terms of numbers that probably we, and again, because sometimes people may even, like this meeting, there are still people who had promised they would join, they didn't join. There are those who had said they would join at some point, they still didn't join. There are those who joined and dropped off not so long after they had joined. So it's really, in a virtual meeting, the dynamics are really, they are really difficult even to predict, because someone may be wanting, they really will to be there, but maybe the internet is an issue. So maybe depending on how many people log in, we may not be able to have the groups in advance, but looking at the numbers that we log in initially, in the first 30 minutes, we can now choose, we can agree on whether we will merge the strategic directions so that we only have 3 teams or 4 teams instead of 7. Maybe we do that in the first few minutes after people log in. But we, in terms of expectation, we are expecting at least a person per county. That should be 47. Yeah.
Okay. Is it only the people from the county? Do we expect anyone from the council, as in from the office that you're liaising with, or only directly from the counties?
Mabel herself will join. She's the focal point at the County Council of Governors. She'll join herself. But I'll ask her if she'll join with someone else or she'll just be alone. But she'll be joining.
Okay, so we are agreeing on we maintain the structure for today. Tentatively, then think about tomorrow, 30 minutes or so into the meeting, we know how many people are there, and we see whether we'll have fewer groups or we maintain the 7 groups as they are. But sort of maintaining the same structure and the same questions. And hopefully maybe some feedback will come through the online platform.
Yeah.
And so far we don't have any feedback based on the tool we gave, right?
No, from end, we've not been able to see
any.
Okay.
Yeah.
I'm trying to find my tool just to see whether the structure for today will fully work or given the questions that we sent. I may not get it.
I think we will have to adapt because the questions are specific to certain issues.
Yeah.
We may need to do a bit of adapting.
And I'm thinking also, in addition to using the guidance we had today, looking at the tool that we had sent out, just to like map out some of their key issues, the challenges from their own perspective at county level. And then we consolidate it with the other set of questions. And also trying to also get to know their vision in terms of adolescent health programming. What does success look like from their angle?
Yeah, because I think their questions are pretty specific, and we don't want to ignore if someone has spent some time. Just now there are 47 people, they can't all speak. Because 47 times 3 minutes, that is how much time?
Yeah, that will be the whole day.
Yeah.
Can we ask that the feedback from the questionnaire we shared, they said it in writing. Then the meeting goes on as we have had for today. Would that make us miss out anything?
My hesitation with that is, okay, if I'm reading between the lines from the response about registering, I don't know if we will actually also get like commitment enough to get a written. So I'm trying to see how we can maximize their presence here to extract everything we need about counties.
Okay. So then, does it mean then, because you can see that today we've gone over by 30 minutes, does it mean then that we need to really squeeze and do things a little faster? Because it looks like besides the feedback on the draft and the different strategic directions, that we still need a little bit more from them, spend a little bit more time with them.
I think so. I think if we have the opportunity to tailor the issues to the counties, I think that would work better. We can reduce the time that we allocate to the more general issues, and then we just have the focus where it's specific to what they do and what they are day to day. I also take the earlier points about asking them about their views, like what success looks to them. We can integrate that because I think it's important, not in terms of specific answers from individuals, but maybe we can integrate that. Sam and Kiragu, we can find a way. I'm just thinking for buy-in, we might want to at least put a county voice into the document. And this is the best forum for us to do that.
Yeah, sure. So yeah, I think that should work. But then it means we have to reduce time. Like I felt like we were given too much time today for group work. We were there in our group wondering whether we have forgotten or someone would ever come for us from our breakout session. I think we went beyond 30 minutes. So can we reduce it to 20 minutes?
And maybe
Is it possible?
Maybe we should have the specific questions, the ones we had sent to the counties with a little bit of tweaking, to have those, because that's the perspective that you're looking for. Like, what are the challenges in terms of programming? Maybe they may not even need to look at the pillars specifically.
Okay.
Then they can tell us what the issues are around coordinating programs and implementation. And what they think this strategy should focus on. Maybe we can